Peptic ulcer disease involves an actual erosion of the GI lining. Whereas gastritis is inflammation of the mucosa, peptic ulcer disease has a true erosion of tissue. The two forms we'll mention are gastric ulcer and duodenal ulcer. In gastric ulcers, the pain is greater with meals. G is for greater. In duodenal ulcers, the pain decreases with meals. D is for decrease. Because gastric ulcers have greater pain with meals, people typically begin to eat less and thus lose weight. This is common in older patients. H. pylori is commonly involved around 70% of cases, but chronic NSAID use is also an important factor. What tests can you do on a patient if you suspect H. pylori infection? Well, these patients have a positive urease breath test. Why is this? Well, H. pylori produces urease, which breaks down urea to carbon dioxide and ammonia, neutralizing the acid environment of the stomach. Duodenal ulcers have decreased pain with meals, so these patients often gain weight. In 90% of cases, ulcers are found in the proximal duodenum. Although most of the gastric ulcers are related to H. pylori infection, nearly 100% of the duodenal ulcers are caused by H. pylori. The effect of this organism is reduced mucosal protection, which allows the normal acid load to harm the stomach lining. Occasionally, however, duodenal ulcers are caused by Zollinger-Ellison syndrome. The gastronoma, in which case the acid load just overwhelms the normal mucosal barrier. Suspect ZE syndrome in a question, especially if you see an ulcer very far down the GI tract. Other clues it is ZE is if there are multiple ulcers and recurrence of ulcers even after therapy. To review some physiology, if you have a gastronoma, which cells are stimulated? Well, to answer, a gastronoma by definition secretes gastrin, which stimulates parietal cells to secrete gastric acid. Ulcers tend to have a clean, punched-out margins look, which you can see here, which make them very obviously different from the raised and irregular margins of stomach adenocarcinoma. The major complications include bleeding, penetration into the pancreas, perforation, and obstruction. Ulcers, along with esophageal varices, are the most common causes of upper GI bleeds. Aside from the possible cancer risk that we discussed earlier, there are other possible complications of ulcers that you should be aware of. The first is hemorrhage, which most commonly happens when gastric ulcers erode posteriorly into the gastroduodenal arteries. The other complication is perforation, which happens most commonly in duodenal ulcers, especially when they erode anteriorly. If this happens, the patient will have extreme abdominal pain and rigidity, and this is a surgical emergency. On X-ray, you can see free air, and this air irritates the diaphragm, causing the pain to radiate to the shoulder. Let's do a question to review GI anatomy and tie together peptic ulcer disease. A patient presents with hematemesis, and you discover a peptic ulcer in the lesser curvature of the stomach. What vessels were likely eroded by the ulcer? It is the left and right gastric arteries. An ulcer on the posterior wall of the duodenum would cause bleeding from the gastroduodenal artery, which you can see here. You can see why this makes sense. If you have an ulcer here, you're going to affect these two arteries. If you have an ulcer here, though, you're going to affect the gastroduodenal artery. Okay, now that we've finished ulcers, let's tackle malabsorption syndromes. There are many different malabsorption syndromes, and they all have similar clinical features. What are they? Well, they're diarrhea, steatorrhea, weight loss, weakness, and vitamin and mineral deficiencies. Some have additional features, which we will highlight as we go through all the different malabsorption syndromes. The first syndrome is tropical sprue, a relatively understudied illness that is considered to be an infectious syndrome because of its positive response to antibiotics. The illness is similar to celiac sprue, which we'll discuss in detail, but the important difference is that tropical sprue can affect the entire small bowel. There is abnormal flattening of the villi and inflammation. Whipple disease is a malabsorption syndrome, typically in older men, that is caused by Tropherma whippleyi. Remembering back to microbiology, is this a gram-positive or a gram-negative? It is a gram-positive organism. Biopsy specimens show PAS-positive macrophages in the intestinal lamina propria and mesenteric nodes. In addition to the typical diarrhea, weight loss, and weakness, patients also have arthralgias and cardiac and neurologic symptoms. The mnemonic foamy whipped cream in a can help you. Foamy meaning think of foamy PAS-positive macrophages, and can, or C for cardiac, A for arthralgias, and N for neurological symptoms. On the exam, if you see a positive PAS stain, think of Whipple disease, as a PAS stain is only positive in a relatively small subset of other diseases. Assume the patient will be a middle to older-aged white male. Celiac sprue is basically an autoimmune disease in which autoantibodies recognizing gluten form and cause symptoms when patients eat wheat or certain grains. It is usually limited to the proximal small bowel. These patients may have a skin rash known as dermatitis herpetiformis, and there is a moderately increased risk of gastrointestinal malignancies. The pathophysiology involves autoimmune intolerance to gliadin, which is a glycoprotein found in wheat and is the major component of gluten. The antibodies are useful in testing for the disease, including anti-endomysial, anti-gliadin, and anti-tissue transglutaminase, or TTG. It is associated with HLA-DQ2, HLA-DQ8, as well as people of Northern European descent. So what would we expect to see on biopsy of the jejunum? Well, we would typically see blunting of the villi, which you can see here, as well as lymphocytes in the lamina propria. This confirms the diagnosis of celiac sprue. Patients can often have complete resolution of symptoms by following a restrictive gluten-free diet. There are various disaccharidase deficiencies as well, lactase deficiency being the most common. Osmotic diarrhea is the main symptom, and biopsies show essentially normal villi. An interesting fact is that self-limited lactase deficiency can occur following a viral illness when the intestinal epithelium is damaged. It is relatively easy to test for possible lactose intolerance. Among the many ways include doing a lactose tolerance test, which is considered positive for a lactase deficiency if symptoms start once an oral load of lactose produces typical GI symptoms, and if the glucose rises by less than 20 mg per deciliter. Why is this? Well, it makes sense because people with lactase deficiency can't break down lactose into its components, glucose and galactose. So if we can't break it down here, glucose monomers won't accumulate and they won't be taken up. So therefore, blood levels of glucose won't be able to rise following pure lactose administration. The last syndrome we'll mention is pancreatic insufficiency. This can be due to many underlying causes, such as cystic fibrosis, which is one of the classic ways in which it is discussed, as well as cancer and pancreatitis. Because there are so many fat-digesting enzymes unique to the pancreas, if you remember back to our physiology section, without these enzymes, there is a loss of fat in the stool, which is called steatorrhea, and also there's an inability to absorb fat-soluble vitamins. You could expect to see all the fat-soluble vitamin deficiencies in a patient with pancreatic insufficiency, especially if it's long-standing. What are the most common fat-soluble vitamins? That's right. It's vitamins A, D, E, and K.